another Sova Health CME program this evening. We're delighted to have you join us. This program tonight provides 1 hour of Category 1 physician AMA CME and 1 hour of Virginia Nurses Association CE credit. Sova Health is accredited by the Southern States CME Collaborative to provide Category 1 AMA CME. It's also accredited by the Virginia Nurses Association to provide nursing CE credit. The program this evening was developed from multiple requests from our medical staff for a program on hospice versus palliative care. It's been developed with the effort to promote several desirable physician attributes, including patient-centered care, our employing evidence-based medicine in our practice, and our working together in interdisciplinary teams. Dr. Curlin, Dr. Quantra, our moderator, myself, and members of the Sova Health CME committee and program have no commercial disclosures to report to you. Similarly, there is no commercial support for this program. The program this evening, along with all of our Sova Health CME programs, is supported by educational grants from the Ralph Landis Medical Education Fund, which resides at the Danville Community College Educational Foundation. Dr. Ralph Landis, who founded the local urologic practice a number of years ago, created an endowment upon his retirement in 1985 that provides support for honorarium for medical education for healthcare professionals throughout our community. At the end of the program, you will receive an evaluation form that'll be emailed to you. It'll also be available, as you'll see on the next slide, through a QR code, link. We ask you to take a few minutes and fill that out. Among the questions, I think there are 7 or so. The number 4 usual question is, how will you change your practice based on what you learned this evening? And we just point out that that's for everyone, not just the physicians, and take a few minutes to share that with us if you would. The form that you will receive for the evaluation form requires you to re-enter your name and email address. Please give us your full name, in as much as that is the name that will appear on your CME certificate. And basically, we can't use short names or nicknames and so forth. If you are logged on with another individual, someone sharing your log on tonight, they are more than welcome. If that is the case, please let myself or Vinay Mayo or Jennifer Goodman know so we can be sure they receive credit for participating in the program this evening. As I mentioned before, there will be a QR code in those final boxes at the chat that you can access that. Once the eval form is received, you will receive back the CME certificate electronically. For our Sova Health medical residents, you do not have to keep up with the CME certificates. We will notify your program coordinators of your participation. Nurses and nurse practitioners are required to complete an eval form in order to receive CME credit. However, that's not the case for physicians. However, we really urge you to do the eval form. It's really important to our speakers as well as for our program and our management of it. I always like to take just a moment to thank the ones who make this possible this evening. That's Vinay Mayo, who is our new CME coordinator. We welcome her. She's doing a great job managing the program with me, and along with Jennifer Goodman, who is a market manager for nursing education here at Sova Health. If you have any questions or needs about the program, please reach out to us. I know Dr. Curlin encourages questions as well as Dr. Quantra. They've asked that those be deferred to the end of the program. You are welcome to enter those in the chat. Vinay and Jennifer will be monitoring that, and they will, if you will, feed them to Dr. Curlin at the end of the program. Very briefly, I want to tell you about the upcoming CME programs we have. In about 2 weeks, on Thursday evening, February 12th, we have a very unique presentation. You may or may not be aware that every approximately 4 years, the National Institutes of Health issues with the American Heart Association and numerous other professional organizations consensus-generated guidelines on the treatment of high blood pressure detection and evaluation, the so-called JNC reports. The 10th such report was published this fall of last year, 2025. Dr. Daniel Jones, Dean of the School of Medicine at University of Mississippi, chaired that group, and he has been kind enough to present the report to us and what changes are being made in the management of high blood pressure. That being said, you probably know high blood pressure is the most common reason an adult sees a healthcare professional in this country if you exclude pregnancy and injuries and acute illnesses. So I hope you'll plan to be on that program. Following that, we are pleased to announce a new series of CE programs for nurses, nurse practitioners. These will be a quarterly event. The first one is February 17th, Thursday evening, understanding the ECO and TDO processes. You'll be receiving announcements from this from Jennifer Goodman in just a few more days. And then finally, on Thursday, February 26th, we'll have an update and review of heart failure management, including those patients who have preserved left ventricular function and those who have decreased function with Dr. David Kalaba. So all that being said, I am delighted this evening to have this program and to have Dr. Curlin with us from Duke. Dr. Brian Quantra, who is the Director of Radiation Oncology here at Sova Health and a Duke Radiation Oncology faculty member, has graciously agreed and volunteered to be our moderator this evening. Brian will introduce Dr. Curlin and help with the program as we go forward. So that being said, Dr. Quantra, if you want to begin, and Dr. Curlin, you can bring your slides up, which should knock mine off, and we are all ready to go. Thanks so much.
Great.
Thanks, Mike. Appreciate it. Y'all can hear me okay?
Yes.
So it's a pleasure, really an honor to introduce Dr. Farr Curlin, who I'm glad to be able to call a friend in addition to a colleague. Dr. Curlin is a palliative care physician at Duke, and he's also the Josiah Trent Professor of Medical Humanities. He is a professor both at the medical school and at the divinity school. Dr. Curlin did his medical school at UNC Chapel Hill and his residency in internal medicine and his palliative care fellowship at the University of Chicago, where he joined the faculty, and in 2012 was instrumental in founding the University of Chicago's program on medicine and religion and in founding the National Conference on Medicine and Religion. We've been fortunate to have him join us at Duke in 2015. He's currently the co-director of the Divinity School's program in theology, medicine, and culture, of which I was very fortunate to take part. He's also a member of the Trent Center for Bioethics, Humanities, and the History of Medicine. And most recently, he's also a co-founder of the National Hippocratic Society, which is devoted to helping medical students and residents discover and inculcate their passion for practicing good medicine. Dr. Curlin is also an amazing author, and I highly commend to you the book that he entitled The Way of Medicine, Ethics, and the Healing Profession, which was a life and practice changing book for me, and I really commend it to all of you. And that's true, Farr. That's not just saying
Thank you, Brian.
So with that, I really look forward to hearing the rest of your talk.
Well, thank you, Brian, and thank you, Mike. Thank you all for joining us just 2 days before a bomb cyclone, which is a term I'd not heard before until this week, but hopefully we can get this talk in before the bomb cyclone goes off. And as Brian suggested, you're going to hear a talk about hospice and palliative medicine, which I practice and have practiced for almost 20 years. So you're going to get that, but you're also going to get this talk from the perspective of someone who wears a hat of a medical ethicist and also teaches in a divinity school in addition to the medical school. So I'm really interested as a practitioner in what good medicine looks like for those at the end of life and what hospice and palliative medicine offer, how we avail ourselves well of what they offer while also understanding and responding well to the concerns that some have, and I'm guessing even among your patients you've encountered this, that hospice and palliative medicine is not for them, that they have reason, perhaps even good reason, to be wary of hospice and palliative medicine. So consider this case. LC is a 50-year-old carpenter. He and his wife are proud parents of twin daughters, and one day LC notices his eyes look yellow and goes to see his doctor. Imaging reveals a tumor in the pancreas with multiple lesions in the liver. A procedure is done to place a stent in his bile duct, and biopsies confirm everyone's fears. LC has metastatic pancreatic cancer. Something like we've just recently learned, Ben Sass, former senator, former president of the University of Florida, has just been diagnosed with. Ben is a year younger than me, so it hits hits home. Anyway, so how does what has come to be called what's that?
CME వస్తుందా?
I'll just keep going here. How does what has come to be called palliative medicine or palliative care fit into good medicine for LC? Since the advent of the positive pressure mechanical ventilator in the late 1960s, the ethical concern most often voiced regarding end-of-life care has been, how do we free dying patients from unnecessary suffering and degradation caused by the overuse of life-sustaining technologies? So patients and physicians alike have decried how a seemingly default pathway for those who die within modern healthcare institutions uses life-sustaining technology to postpone death as long as possible. I'm sure all of you have seen many versions of this image. And by trapping patients in a technologically driven institutional matrix that imposes undue suffering and isolates the patients from their communities, this default pathway seems to prevent patients from dying well. And the primary strategy of healthcare to address this problem has been to expand and to enhance palliative care and hospice. And hospice and palliative care, as they've come to be called, or hospice and palliative medicine, have been expanded markedly. So much so that in our day, in the present, LC is likely to be offered, and perhaps his doctors will even recommend, a palliative approach to his illness, an approach that will focus on symptom control and function, and will set aside chemotherapy, radiation, and surgery. So what are palliative care and hospice? What's the difference? When is a patient ready for them? Well, hospice is a structure for organizing and paying for, usually via Medicare, the medical care of patients expected to live less than 6 months who are willing to forego hospitalization and other costly disease-focused interventions. It's again structured as a separate insurance benefit, but it's a way of organizing care. It includes a package of benefits that obviously include medications, equipment, nursing visits, social work, and chaplains, and add-ons depending on the hospice agency, like massage. Home hospice can be provided in a residence, a person's home, or in a nursing facility. Inpatient hospice is available only to those requiring intensive, skilled nursing assessment and intervention, typically people who are actively dying or who've had some sort of crisis at home. And then there's I won't go into this too much, but there's an in-between called residential hospice, where if patients have some means of paying the kind of room and board of a nursing facility, they can get a kind of quasi-inpatient hospice care, usually for a month or two, whereas inpatient hospice is usually somewhere people will stay just for a matter of days. Palliative medicine, by contrast, is a medical specialty focused on the relief of difficult symptoms, including, of course, pain, shortness of breath, nausea, agitation, pruritus, itching, and other difficult symptoms, and which helps patients, family members, and clinicians negotiate complex decision-making at the end of life. Patients in hospice receive primarily, but not exclusively, palliative medicine. It's an important caveat. Even though what people mostly get in hospice is palliative medicine, they also can receive management of their heart failure, you know, treatment of seizure disorders, treatment of even urinary tract infections or respiratory infections. It's not strictly palliative medicine, but it's primarily palliative medicine. Palliative medicine focuses primarily, but not exclusively, on patients with terminal illnesses. So I would say, in my experience, probably of the patients that a palliative medicine doctor like me sees, an inpatient palliative medicine consultant, 90% are people that would qualify for hospice. Patients are ready for palliative medicine when they have advanced illness and symptoms that are getting in the way of their vocation. Patients are ready for hospice when medicine no longer offers disease-directed treatments that cannot be provided in hospice or at home that have realistic benefits proportionate to their burdens. So whenever someone comes to the point where that medicine, which can offer them the benefits that are available to them, can be done at home, and that which can't be done at home doesn't really offer them proportionate benefits, they're ready for hospice. Hospice and palliative care, or hospice and palliative medicine, do much to help patients who are dying. And to begin, hospice and palliative care provides a viable alternative to that default pathway I spoke about before, a way to get off the technological medicine train. For the most part, patients and physicians agree that whatever dying well entails, surely it entails more and less than keeping one's matter in motion as long as possible, in a way that's isolated from one's community, and it's under the control of machines and a system of processes that go on with a kind of relentless, often impersonal logic. This default pathway makes it hard for patients like LC to die well, because it puts off preparation for death through vain implicit promises to extend life indefinitely. And the overuse of life-sustaining technology absorbs time, it absorbs attention, and it absorbs other resources that could be devoted to other more worthwhile tasks. So just for an example, driving back and forth to the hospital leaves less time for reconciling with one's spouse or neighbors or children. And it's difficult to pray or write letters to one's loved ones or to organize one's estate while retching from the side effects of chemotherapy. Moreover, the default pathway isolates patients like Elsie, as we can see even in this image, isolates them from their communities, and I think here particularly of religious communities, that can guide and support the patient in living well in the face of death. So, if nothing else, the growth of hospice and palliative care has removed the taken for grantedness and weakened the grip of this default way of dying. Hospice and palliative care also creates a recognizable social space in which we can say that a patient is dying. We can use that language, not merely sick, but dying, and allow the patient, therefore, to take on the dying role. In his book, Being Mortal, the surgeon-writer Atul Gawande writes that one of our challenges in caring well for those who are dying is that it's hard to say when someone is dying. Because, he writes, technology can sustain our organs until we are well past the point of awareness and coherence. How then do you attend to the thoughts and concerns of the dying when medicine has made it almost impossible to be sure who the dying even are? Is someone with terminal cancer, dementia, or incurable heart failure dying exactly? Is Ben Sass dying? Is LC dying? One of the refreshing aspects of my work in hospice is that in my encounters with patients, once they're in hospice, the pretense of fixing the problem is gone. Everyone's agreed that the patient is dying. Not necessarily within hours or days, but soon and for certain. And that agreement has a way of focusing attention on how to support the patient as he or she dies. So for medical practitioners, what can be done now to be helpful in the face of certain and imminent death? For the patient, like LC, how do I go on in the face of and in preparation for the death that I cannot avoid? For LC's wife and other members of his community, what does it mean to keep faith with and company with LC on this final part of his earthly journey? Moreover, by locating the social space of dying within the geographical space of the patient's home rather than in the ICU, and by opening the geographical space of the hospital to accommodate the presence and participation of the home community, which once you get a palliative medicine consultant and someone opts for comfort care, that generally happens. There's expanding, there's a loosening of the visitation rules, and there's food provided, and there's a kind of more of a welcome to that community. In that way, hospice and palliative care removes institutional barriers that, in the default pathway of technological medicine, keep patients.
Did we lose Dr. Carlin? Audio?
Yes.
Đấy thì chắc là nó như xây mà đâu.
I looked like somebody muted me by accident. Can y'all hear me?
Yes, we can hear you.
Now.
Yes, sir. I think you lost about one slide.
All right, let me, great, let me go back to.
We heard you read Atul Gawande's quote, and you were, I think, midway through that slide.
That's weird. All right, let me do that again. Hang on one second.
You also need to go to slideshow.
Yes, I will.
Thanks.
Mhm. All right, do you see the full slide now?
Yes.
Okay. So I was saying one of the refreshing aspects of my work in hospice is that in my encounters with patients, the pretense of fixing the problem is gone. Everyone agrees that the patient's dying, not necessarily within hours or days, but soon and for certain. And that agreement has a way of allowing us to focus our attention on how to support the patient as he or she dies. Moreover, because hospice and palliative medicine generally moves the social space, you might say, of dying into the geographical space, generally, of the patient's home, and it opens the geographical space of the hospital with all its bells and whistles to accommodate the presence and participation of the home community. You see this whenever someone becomes comfort care, signage changes, food is brought, visitation rules are relaxed. Hospice and palliative care removes, by the way, and if you go to inpatient hospice, there's parking that's close, there are places for people to stretch out. This removes institutional barriers that in the default pathway of technological medicine keep patients, family, and friends and clergy off balance and at arm's length. I mean, arguably, for a patient like LC, the most important part of living well in the face of his impending death will happen in the relationships with those to whom he belongs. His family, his friends, maybe people from his religious community. And because hospice and palliative care moves him generally out into the community and invites the community into the spaces of healthcare, it helps those folks feel welcomed and empowered to contribute what LC needs to die well. So let's suppose 2 weeks after his diagnosis, LC returns to see his primary physician, and he looks tired, he looks sad, and he notes, I'm not sleeping well, I can't concentrate or enjoy anything, not even being with my grandchildren, because I'm so anxious about what lies ahead. I'm not ready to die, he says. Why would God do this to me? LC's presentation here highlights another way that hospice and palliative care helps patients who are dying, and that is by attending to the spiritual dimension of patients' experiences. The National Consensus Project for Quality Palliative Care identifies spiritual, religious, and existential aspects of care as the fifth of 8 core domains of palliative care. And it's not alone in doing that. If you look at the World Health Organization's guidelines about palliative care, if you look at the International Association for Hospice and Palliative Care, the Joint Commission, wherever you look, contemporary visions of quality end-of-life care now universally include attention to the patient as a spiritual being. And in all these ways, then, hospice and palliative care helps patients who are dying. And notice, this is prior to relieving any symptoms, right? Prior to treating pain. But I propose to you, and here's the wrinkle, here's the tension or the rub that it's important to understand and negotiate. I propose to you that palliative care can also undermine and contradict the possibility of LC dying well. It can do that first when it seeks to comprehensively manage LC's spiritual concerns. That can usurp the roles that the patients and family and community play in what was once called the ars moriendi. That term, which means simply the art of dying, refers to a literature that emerged in the late Middle Ages, particularly in the 16th century, in response to that century's episodes of the plague. There were so many people who were dying that the church could not keep up with the usual rituals and practices of accompanying with those who were dying. And in response, the church affirmed and helped to promulgate a set of prints and booklets. This kind of was really a layperson movement, but then the church got behind it and endorsed it. These to guide lay people and those around them in preparing to die faithfully and well. These initial prints and booklets expanded to a literature that was disseminated all over Europe and which shaped the way people lived and died for centuries. So for my purposes this evening, when I use the term ars moriendi, I'm simply referring to the idea of dying well, which, as we'll see in a moment, importantly, is different from a conventional notion of a good death. So for the moment, note that hospice and palliative care risks usurping the roles that patient, family, and community play in the ars moriendi if and when it pretends to deliver a kind of professionally packaged replacement form of spiritual care that would substitute for the part that a religious community might play in the person's deathbed. But I think the most problematic way that hospice and palliative medicine can undermine the possibility of LC dying well, and this is the reason we see so much resistance among many people in the community, is when hospice and palliative care removes the conditions needed for patients to participate in dying well. And this is often done unintentionally. Do you guys hear me?
Yes, you're good.
Yes.
Okay, good. Just checking. The medications that relieve symptoms have side effects. Opioids, antipsychotics, benzodiazepines, these can all relieve pain and anxiety and restlessness, but they also diminish consciousness. And they reduce patients' capacity to be really relationally present to others, to communicate, to pray, or to engage in other activities. And in so doing, these treatments can render patients passive to the process of dying, and therefore
It's real slow, but
Dr. Curlin's muted again.
Somebody keeps hitting the mute all when they're trying to mute everybody. Please make sure your personal mic is muted. Don't do mute all, please.
I think I'm back now, but thank you for speaking up.
Sorry, yes.
Not at all. Let me see. Okay.
We didn't lose much there.
Okay,
That was
great.
short.
So when the use of these medicines, which are very important medicines, but when they suppress consciousness, that can put people existentially kind of out of reach of their communities. And that's been a prominent concern of many patients and their family members for whom I have cared within hospice. In the Ars Moriendi, clergy, lay counselors, not to mention family members, friends, even doctors can accompany with, can attend to, can be present to patients in the patient's suffering. And this practice of presence goes to the heart of medicine. It's expressed, I think, in the term attending physician. That speaks to the central, maybe you might say constitutive thing that we do is we show up and attend to those who are sick. But when the patient's consciousness is sufficiently diminished, then they can't experience that presence of those around them. So I think this raises a challenge for us. How do we navigate the tension between our obligation to relieve suffering and yet the problem of diminishing the conditions that patients need to die well? I think navigating that tension begins with recognizing that relieving suffering is not the only good at stake. That when a patient is rendered unable to consciously participate in the activities of preparing for death and to experience those around them accompanying with them, then that patient has suffered a loss of something valuable. And hospice and palliative medicine practitioners, as physicians generally, in my experience, we're often in danger of not recognizing these side effects of our treatments as losses, as adverse side effects. Rather, it sometimes seems as if the goal of comfort comes to displace all other goals. And when that happens, we treat consciousness and the patient's participation in their own dying as something trivial. So I propose that to help those who are dying to die well, without undermining that possibility, palliation should be understood as a set of practices internal to medicine, rather than as a rival form of professionalized care. And as part of medicine, palliation should be directed toward health, aiming to relieve suffering just insofar as suffering is related to health. And I'll explain this, but here we begin to see how contemporary medicine and medical ethics can go wrong in a way that terminates, frankly, in something like medical aid in dying. They go wrong by denying that medicine has, first, that it has a rational end or purpose, a reasonable purpose that we don't just make up, but instead recognize and respect, and which gives medical practitioners a standard to guide their practices. There have been times and places in history in which it was axiomatic, it was to be taken for granted that the purpose of medicine was health. So Aristotle wrote famously, right at the beginning of his most famous book, his Ethics, he said, "Now, since there are many actions, arts, and sciences, their ends also are many. The end of the medical art is health, that of shipbuilding a vessel, that of strategy victory, that of economics wealth." So Aristotle clearly thought that the notion that medicine is for health was a starting point for practical reason. It was obvious, it was basic. It's something that all the many and the wise know. That's no longer true. There have been deep cultural shifts in the modern era that have resulted in widespread skepticism regarding any claim to know what are the proper ends of different human identities and activities, including the activities of medicine and the identity of a physician. Despite that skepticism, I'm not going to here defend the conclusion that the purpose of medicine is patient's health. Rather, I'm going to attempt to show what that idea implies, what difference it makes for what we think about in trying to care well for LC and patients like him. So if the end or purpose of medicine is health, then palliative medicine, practiced as one branch or specialty of medicine, will look different than palliative care, practiced as a broader and alternative form of professionalized caring. Within a medicine aimed at health, practitioners who focus on palliation have a reasonable basis for doing things that preserve and restore health, and for not doing things that diminish health or undermine the conditions necessary for patients to entrust themselves to physicians when those patients' health is threatened or diminished. I will acknowledge that it seems counterintuitive to many to think of palliation as aiming at health. Palliation, it seems, is what we do precisely when health can no longer be restored. When, to take LC as an example, we know we will never again say that the patient is healthy. But this common way of thinking misunderstands health and misunderstands palliation. As Leon Kass, famous critic of medicine, philosopher, medical ethicist, as he memorably put it in his 1972 essay regarding the end of medicine and the pursuit of health, health is the well-working of the organism as a whole, or put another way, an activity of the body in accord with its specific excellences. The health of a squirrel, Cass notes, is displayed in the characteristic activities of squirrels, such as bearing nuts, chattering, and climbing trees. Because the characteristic activities of humans are more varied and diverse, so are their expressions of health. But such expressions include the capacity to move one's bowels, to eat and digest food without vomiting it up, to sit or lie or walk or stand without racking pain, to stay awake and to fall asleep at the proper times. Moreover, those are all things that palliative medicine helps people do. Health is also a matter of degree. Obviously, physicians cannot return LC to a state in which we would say he is healthy, but if they help him along the way to go from a state of nausea and constipation and insomnia and racking pain to tolerating food and moving his bowels and sleeping 6 hours a night and moving around free of debilitating pain, then they will have contributed, I think, objectively to LC's health. And it's just these sorts of contributions to health that make it possible for patients to engage in the tasks of dying well, to engage the task, put differently, of living as well as they can in the face of their impending death. The typical tasks of the Ars Moriendi were not physically demanding in the usual sense. They don't involve climbing mountains or running marathons, but they do require some attention, some thought, often some communication through voice or writing, often being present relationally to others. And all of that is made very difficult by racking pain and breathlessness and vomiting and constipation and so on. By treating and relieving these disabling conditions, then, palliative medicine helps to restore that measure of health that patients need in order to participate in and not merely be passive to the task of dying well. Now, here an important distinction comes into view. It's one thing for health professionals to palliate disabling symptoms with an eye to preserving and restoring a measure of health, a measure, again, that makes it possible for the patient to participate in dying well. It's another thing for healthcare professionals to palliate symptoms without respect to whether doing so restores health. And I think the problem, or one of the really major problems of our time, is that physicians are tempted to elide or ignore this distinction, or to treat it like it's of no clinical or ethical significance. So, returning to our case, let's say that LC goes through some chemotherapy and his disease progresses, and he sees his primary physician and says, "Doc, I don't want to languish and suffer in the final stages of this disease. If I come to the point in which I cannot tolerate living any longer, and if I ask you to do so, would you sedate me to unconsciousness and keep me that way until I die?" At a later visit, let's say he adds, "It's very important for me to have some autonomy and control at the end of life. I don't expect I'll need to use it, but would you provide me a prescription for medicines I can take to end my life if I cannot go on?" So, how is it that the good people of California and Oregon and Washington and the District of Columbia, Colorado, Vermont, Hawaii, Montana, New Jersey, New York, Illinois, the list grows by the year, have come to see sedation unto death or physician-assisted suicide as perhaps the most reasonable courses of action when they face the prospect of losing their capacities? There's more to be said than I can say here, but it seems to me that our late modern culture does not form in the average person a capability of receiving unwanted suffering and death and loss of control as anything other than meaningless burdens, much less form them to be capable of receiving these burdens as invitations to grow and to live well in the face of debility and death. And when the meaning is gone from, or the possibility of meaning in the context of suffering is gone, and the suffering remains, then the putative goal of medicine to preserve and restore, let's say, LC's health, seems to a lot of people beside the point. It seems then that the only reasonable response to unwanted suffering is to get rid of it. And under the cultural pressure that that brings, and the way it seems that that's required by genuine compassion, then the medical profession has been steadily setting aside. Those who are for this evolution might say they're overcoming the constraints imposed by aiming only at health. And medicine's been taking on more expansive aims. For example, the World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families, facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Now, you note how this formulation seems, at least it seems to me, to give palliative care a seemingly boundless scope of responsibility. What problems, after all, are excluded from the categories of physical, psychosocial, and spiritual? Note also that in this formulation, medicine does not aim to preserve and restore a measure of health, but instead to relieve suffering and improve quality of life. And when efforts to relieve suffering and to improve quality of life break free from the limitations imposed by medicine's traditional orientation to the patient's bodily health, then physicians begin to see all forms of suffering, including existential or spiritual suffering, as conditions which call for medical treatment. And because palliative care, in particular, seeks to minimize suffering and maximize quality of life, and because suffering and quality of life can only really be assessed authoritatively by the one who's suffering, palliative care's practitioners come to trade their own clinical judgment as physicians for the direction given by patient preferences or patient's goals. And the language of patient preferences links the goal of control over one's destiny together with the goal of freedom from unwanted suffering. The American Association of Hospice and Palliative Medicine makes this link explicit, writing, "The goal of palliative care is to prevent and relieve suffering and to support the best possible quality of life for patients and their families, regardless of their stage of disease or the need for other therapies, in accordance with their values and preferences." If LC's physician sets out to minimize LC's suffering, maximize LC's quality of life, and do so in accordance with LC's values and preferences, then it seems that the physician has a good reason to aim at LC's death itself as one of her goals, so long as that's what LC believes his values and preferences and quality of life and so on require. And a growing proportion of the public and of the medical profession over the last 20 years has come to think in just this way. So we find that the palliative care literature speaks less about relieving disabling symptoms so that patients can live as well as possible in the face of death, and it speaks more about treating unwanted symptoms so that patients can die comfortably. Just to give one prominent example here, the National Hospice and Palliative Care Organization describes hospice as follows, quote, "Hospice affirms the concept of palliative care as an intensive program that enhances comfort and promotes the quality of life for individuals and their families. When cure is no longer possible, hospice recognizes that a peaceful and comfortable death is an essential goal of healthcare." So note these shifts. You have a shift from aiming at health to maximizing quality of life, a shift from proportionate relief of symptoms to minimizing suffering, and a shift from helping patients who are dying in hopes they can die well to helping patients to die by delivering them a good death, where a good death is a death the patient chooses, or at least the patient accepts on their own terms, and which is as free of suffering as possible. These shifts may seem subtle, but they're quite consequential for how we think about what it means to care well for patients like LC. So to put it plainly, when the goal of medicine shifts from helping patients who are dying to helping patients to die, practices that render patients unconscious or that directly hasten their death, they no longer seem like last resort options as they often have been called over the last 20 years. Rather, such practices, and I include here palliative sedation to unconsciousness, doctors encouraging patients to voluntarily stop eating and drinking, assisted suicide, of course, and euthanasia in Canada, They seem to follow ineluctably from making the relief of suffering and satisfying patient choices medicine's first principles. So why turn back from this? Why constrain palliative care for patients like LC to the traditional goal of medicine, namely health? Well, boundaries help to resist against endemic temptations. I'm certainly not suggesting that suffering is good in itself or that we should ignore patient suffering, by no means. But physicians who care for patients with advanced illness have long known that both they and their patients will at times be tempted to do away with the suffering by doing away with the sufferer. And to mitigate against that temptation, physicians have for 2+ millennia sworn in the Hippocratic Oath, I will neither give a deadly drug to anybody who asks for it, nor will I make a suggestion to this effect. The AMA has maintained since its founding, of late against some efforts to get them to change this, but to this point they've sustained this commitment, that physician-assisted suicide is fundamentally inconsistent with a physician's professional role. The World Medical Association has opposed assisted suicide and euthanasia since it was formed and issued the Declaration of Geneva just after the Second World War. Indeed, insofar as physicians enjoy the trust of patients made vulnerable by illness, it is because, since Hippocrates at least, they've maintained solidarity with those who are sick and disabled, seeking only to heal and refusing to use their skills and powers to do harm. That's why physicians have refused to participate in capital punishment or to be active combatants in war or to help patients commit suicide. And importantly, this boundary against diminishing or destroying the patient's health, it not only gives patients a reason to trust physicians, but as I've experienced many times, it gives physicians the freedom that they need to do their work. So for example, when I take care of patients and their families who are wary, and this frequently happens, they're wary of what hospice will do to the one who is dying. They're worried that we're going to just drug the patient quickly and put them out of reach. It helps very much that I can tell those families that as a physician, I'm committed to never intentionally hastening or causing a patient's death. That boundary creates a space in which I and other physicians can act decisively to palliate the distressing symptoms we see. And we can accept side effects, including the side effect of sedation, and including the side effect of hastening death unintentionally, if we can accept that if we have proportionate reason to do so. And this commitment to never intend harm to the health of LC or anyone else gives family members reasons to put aside their worry that the morphine that leads to sedation is dosed not in proportion to the pain or the breathlessness the patient's experiencing, but in an effort to kind of hurry the dying process along. This question of trust is paramount. People in our plural culture have trusted institutional medicine in no small part because preserving and restoring health is a goal that's shared broadly across diverse moral traditions and communities, and this has been true throughout history. Assisting patients to die is not a goal shared in the same way, quite the opposite. How and to what extent suffering should be treated is also the subject of widespread disagreements, particularly when that suffering is not obviously related to health. And already the work of hospice and palliative medicine is inhibited, and I've experienced this very directly in my interactions with patients on the south side of Chicago, where I worked for several years, and then here in Durham, North Carolina. But it's inhibited by the fact that many Americans, and particularly among minorities and racial minorities and among some religious communities, they're suspicious that that hospice and palliative medicine has kind of unmoored itself from the constraints traditionally respected by the profession of medicine. That we've moved from proportionate palliation, for example, to rationalized processes of smoothly helping people die. And when physicians set themselves outside those traditional constraints and goals, and when we fail to recognize and respect the value of what was once called the ars moriendi, it seems to me we are eroding the public trust that we will need, that we need now and will need in the future to provide appropriate palliation to patients like LC. If, insofar as patients like LC distrust hospice and palliative medicine, they're going to go without all the good that hospice and palliative medicine can do to contribute to the conditions needed to die well. So, to summarize, and I'll close with this. Medicine and palliative medicine can do much to help those who are dying if medical practitioners humbly acknowledge that dying well is an activity primarily for the patient and their community, to which medical practitioners contribute insofar as they help to make the activity possible by mitigating distressing symptoms, maintaining function, sustaining a location in the community when that's possible, providing realistic information, and reassuring presence, but which medical practitioners can hinder or undermine if they presume to deliver a good death by removing the capacities that make suffering possible. So by setting palliation within and under the constraints of medicine and its focus on the patient's health, rather than as an alternative and more expansive form of professionalized care, physicians can, I think, sustain a proper humility and focus on a limited but very important role. Rather than usurping or undermining the ars moriendi, they would work to preserve and restore the measures of health that make it possible for patients to engage in the tasks of dying well. Thank you much, and I'll stop there.
Thank you, Far. I think you need to keep that slide up. If you're interested in studying this
I will,
DOC
yeah.
slide, because that program is wonderful, and I recommend it. Far, thank you for a great talk. I always learn something whenever I get to hear you speak, and I'm grateful for the very thoughtful presentation on what hospice and palliative care medicine are really all about. So I would agree, in my experience as an oncologist dealing with many people who are on the verge of these this time in life, that one of the major areas of resistance that the patients have to entering hospice is the idea that hospice will actively hasten death. And I think that's becoming more of a problem, and I think you're spot on with identifying these changes as a threat to the proper functioning of hospice and palliative medicine. Something that does bother me about hospice care, and it's been just a growing concern for me. So when we meet at the Trent Center and we talk about what good medicine is and how to practice it, some of the common themes that come up are how important the patient-physician relationship is, how the physician can heal and promote health through that relationship, through accompaniment, through solidarity, maintaining solidarity with the patient, through witness for the patient. And the problem with hospice as it's currently set up is that I feel that when the patient signs up for hospice, there's this severing of other doctor-patient relationships that I think the patients can interpret, and in fact do interpret, as being abandonment. I think it also can be traumatic for us as the physicians when you really care, and to have this sort of this artificial imposition put into place. I also have some concerns about the financial incentives. The financial incentives are perverse in every way and throughout the system, but the hospice ones that really constrain the use of even proper palliative techniques, such as giving one fraction of radiation therapy to an extremely painful bone metastasis, that becomes very difficult to achieve in practice with hospice care, even though theoretically it should not. So I'm interested in hearing your thoughts on those issues.
Yeah, those are good questions, Brian. I mean, yes, it's true that hospices have a perverse incentive to forego things, basically to save money wherever they can, because hospices are paid a per diem set by Medicare or other insurers, and as long as they meet their statutorily required basket of resources, they can save money. And if they save money on their expenses, then they'll improve their bottom line. In my experience, the better hospices generally, I'm not saying this is across the board, but are well established nonprofits that often make it a point to try to make available things like a single palliative radiation treatment for a painful met, spinal met, or other kind of bone met, or any kind of met, or they'll make it possible to get blood transfusions for people who are slowly bleeding over weeks, and so they can live a few more weeks as long as the bleeding is slow, things like that. But it's not always true across the board. The more fundamental thing you mentioned was, yeah, it is a real problem. It's not, of course, specific to hospice, but it is true in hospice that once people enter hospice, it's only the minority of cases that their previous physicians maintain any contact with them, or they with their physicians. And when a patient goes into hospice, they will be asked, they or their family, do you want the hospice physician to write the orders? Or actually, the referring physician will be asked, do you want to write the orders, or do you want the hospice physician to write the orders? And most referring physicians, I understandably think, I don't want to be called in the middle of the night, and these hospice docs know what they're doing. And there is a kind of funnel where I think the orders get simpler as you're getting closer to death. So great majority will say, let the hospice doc do it. And once that happens, it's a minority of physicians that will ever see their patient again. So that is problematic. I think it's also a function of the way just across medicine we are, there are not many physician-owned practices where you take care of somebody for 20 years and see them through to the end. It's just people are kind of interchangeably providing services in clinics, and for, I think, a lot of physicians, just once a patient goes to hospice, it's almost just it's a reduction in the burden that they're under, because their time is already full, and it's not that they want to abandon their patient, but there aren't really, things are not structured in a way to give them an incentive to keep that relationship alive. But it's a problem.
Yeah, I mean, I just, the only way I've been able to see those patients is to drive to their house or to drive to the inpatient hospice, and it's really a challenge.
I should say, and that's of course particularly true for someone like yourself, a radiation oncologist. I should say, for those, as a point of clarity, when someone comes into hospice by Medicare rules, and these are followed generally by other insurers, because all the insurers model their benefits after Medicare's hospice benefit, patients can designate one physician that they can see. That could be their oncologist, it could be their cardiologist, it could be their primary care doctor. But they can see that one physician, and that one physician can be paid for a regular E&M visit for seeing them. That's just one. But even though that's possible, it seems to me not many patients avail themselves of that.
We have other questions?
Dr. Curlins, Dr. Moore, one of the dimensions that I learned about in palliation or palliative medicine was really trying to focus on what the patient's goals or what they felt would be of value to them, in so many words, time remaining. Can you comment on that and how that fits into your comments tonight?
Yeah, I'm glad you brought it up, Mike. I have a kind of love-hate relationship with this language. So and the language is goal concordant care. We often hear the term, we're going to have a goals of care discussion. For example, you'll see in a note they had a goals of care and the family opted for comfort measures or something like that. I think that makes sense insofar as it reflects a recognition that it's time to consider whether the things that can be done are things that the patient really, all things considered, believes should be done for them. And that sort of discernment is good and right, and unfortunately doesn't happen a lot in medicine. There's such an impulse to a therapeutic kind of impulse that doctors think, well, if you qualify for a treatment, then obviously you should have that treatment. But particularly when people are at the end of life, we can start to see that way of approaching medical decision-making doesn't serve patients well. So in that sense, the goals of care language makes sense. These are things we could focus on. We can focus on trying to get fluid off your lungs, but you're probably going to be dehydrated some. We can focus on we can do several treatments of palliative radiation, but you'll need to be in the hospital maybe for another week if we're going to do 6 fractions. Or we can just do 1 and try to get you home. And, we try to fit what we can do to what the patient's willing to consent to in an all things considered way. The way that I don't like the language is that we sometimes use that language, goals of care, reflexively, as if we don't know what we're up to in medicine until people tell us what their goals are, as if like whatever their goals are, we're supposed to pursue that, including, let's say, my goal is to die. And I think that's problematic when physicians act as if it's the goals that give us our direction. It seems to me rather, we already have our direction. We're going to attend to the patient's features of their health that we can reasonably help and preserve and restore, but we're only going to do so with the patient's consent, and we're going to allow them to tell us that thing that you might want to do, not something I'm willing to go along with, not something that really fits for this point in my life. That, yes, I would accept that.
Yeah, one of the things that really impressed me a few years ago when we did a similar program to this, and I think I shared this with you when we talked earlier in the week, was the actual randomized study type data that if you engaged a palliative care consultant who spoke to the patient about what the patient would like to be able to do, avoiding the word goal, I guess what it really translated in was to promote and sustain the patient of some degree of hope that they can still accomplish things, going to the child's graduation, attending an event or something that's important to them, that it actually in randomized prospective trials showed an extended life. And there was a great importance to including a palliative care consultant or perspective as one cared for people who had very advanced illnesses. That to me was really, really impressive. And it really speaks to the importance of our trying to maintain hope in our patients, no matter what we're trying to treat them for or to improve.
And I will say I've observed, and I've come to think it makes a lot of sense that when done well, a palliative approach often will lead to a longer life for patients. And I'll tell you just a couple of ways it does that. One is it often the things that we're doing to people with advanced illness are actually, they're just killing them faster. And that's just frequently true. And other thing that happens is if you get people into, there are some conditions, chronic heart failure, congestive heart failure, COPD are 2 prominent examples where if you get them into hospice and you have a good hospice nurse, they get the kind of attention and tweaking and pulling off things that don't work and empirically adjusting the medical regimen to find the, that which gives benefit without having adverse side effects, such that those patients often find after a month on hospice that their COPD or CHF is better managed than it ever has been. And I've had patients go on like that for years in hospice.
Dr. Quantrill, let me just step in. Vinaya, I don't see any questions in the chat. Does anyone on the call have questions of Dr. Curlin or Dr. Quantrill? Please just go ahead and speak up. You're among friends.
Dr. Moore, we did have a question from Kim Grossman where wanted to know what is available locally for hospice and palliative care. We did have Tiffany Plunk respond with an answer with Mountain Valley Hospice and Palliative Care, but just wanted to know if Dr. Curlin had anything additional to add.
Thanks.
I don't. I know my own little backyard here, but I don't know north of here really.
I would suggest probably checking with the SOFA Health patient navigators as far as immediate resources here. They are terrific in having a view of what services can be had. I know that is also true for our case managers for our inpatients at SOFA Health, and I'm sure it's true at Duke University Schools of Medicine's medical center. The case managers really have a tremendous set of resources. and these can be accessed. So hopefully that helps with that question.
Yeah,
Any other?
that's the right answer, Mike, because it really depends exactly on where the patient lives. One service will cover one small area and another service covers another, and they have
Right.
different availability.
But those services are available in the greater Danville, Martinsville communities, which is our main community here that Sova Health speaks to try to help. Panay, are there any other questions or anyone just want to speak up, please?
There are no additional questions in the chat.
Thanks. I guess then we're actually just right up spot on time. Let me just tell everyone on the call, some of you, 8 or 10 of you have had a great difficulty getting in this evening. Please accept my apologies for that. This happens occasionally with teams, and we're so sorry if you joined us late. This program was recorded. It'll be available on the SOVA website probably next week. You can listen to the entire program in its entirety. And I'm sorry you had trouble getting on for those of you who experienced that. Myself, I am not a Teams kind of guy in the sense of understanding the technology. And that's why we have our staff help me with that to make it work. Let me thank Dr. Quanter for coordinating and helping me in developing the program and serving as moderator. Dr. Curlin, thank you so much. This was such a really, really good discussion. Thank you so much for doing this. Likewise to Jennifer and Vinay, who have been back in the CME program control room, as it were, helping with all the issues that have happened this evening. So that being said, I hope you will come back and join us on February 12th when Dr. Dan Jones from Ole Miss School of Medicine